So we have taken an 8-year-old male child for diagnostic cystoscopy now, who has presented as urinary incontinence. It was a case of anorectal malformation to begin with, and all 3 surgeries for anorectal malformation has been finished. In addition, the child had hypospadias. It was a penoscrotal hypospadias. For this, 2-stage surgery was done. First stage was Brca's stage 1, and then tubularization was done later on. Patient developed urinary incontinence after that. We investigated the urinary incontinence and did an MRI of the spine, which showed some lipoma and a tethering. For that, detethering was done by a pediatric neurosurgeon, but the child is still incontinent, urinary incontinent. We are going to do a diagnostic cystoscopy in this patient now. I will hand over mic now to Dr. Prema.
Yeah. So I want to make a few comments first. One is that this child born with ARM had penoscrotal hypospadias.
So the patient was incontinent after the second surgery of hypospadias.
That's what I am coming to. So the child has undergone ARM surgery, but after I talked to the mother, I realized that because of the very proximal urinary meatus, the mother is actually not at all sure how the child was passing urine. I think it's almost like scrotal hypospadias. So this is a very important thing to remember, that she's not really sure. If you cross-question her, she's not really able to tell when she noticed the incontinence. So I think that we have to remember. Also, there is a distal cologram, and you can also see in that the dye goes away very quickly lower down somewhere. Can you show that distal cologram? So this is the first distal cologram. So you can see some pooling of contrast lower down. Although I mean,
and please show the distal cologram.
Can you see it?
It is being released. This is the screening.
Yeah. So you can see that now. You can see the pooling of contrast. So we don't really see much of urethra because you just have a proximal urethra most probably. And after the ARM surgery, one more cologram has been done. So again, you can see that urine is dribbling out. I mean, although this is khair to cologram hai, so that is out of the situation. But you can see in the first picture. Okay, now we'll go to the, I think there is an MCU. Can you show the MCU? Okay, so here what I felt is the bladder capacity is good. Although you can see the urethra, there are 2 MCUs. Probably this is the second one, I'm not sure. Can you show the first one if it is there? There is another MCU I thought. Yeah, this MCU. Yeah. So again, you can see the, you just see the posterior urethra. So that's just for the hypospadias part of it. What I'm trying to say is that with that meatus and a small child and Cordy also, the mother may not have really observed the continence of this child. So after this, ARM procedures are completed. Child has undergone hypospadia surgery also successfully. Now the meatus is in the glands. Now after some time, the mother around 5 years of age has actually noticed that the child is incontinent. So probably passing urine every 3 hourly, but also dribbling. If you can just hold it. So actually I felt that, it's not reported, excuse, just one, sorry. So I felt actually that there is a kidney on the left side. I felt, I'm not very sure. It's not reported because it was done more for the spine. So you can see the right kidney and what I think is the ureter. And there is another shadow there which I felt was abnormal, which is a bit lateral over there, a very small structure. And in some films, I at least thought that a ureter is visible. Yeah, which is probably going out somewhere. I'm not sure. This is not reported. Yeah, this side also I can see. But it's not reported, apparently done for the spine. So here they have diagnosed some tethering of cord, some lipoma, L5S1 region, and then detethering has been done. But I don't think, and the mother clearly says that the continence has not changed after the detethering. So that's one thing, because I have a doubt about the kidney on the left side, although Dr. Deepak will tell us more because he has some more information. So now we'll do the scopy. So you can see the, I don't know whether how much you can see with this. So can I go in now? Okay. So this is a 0 degree scope. Now I would have preferred 30 degrees to look at a ureter. So we are going inside. So there is no narrowing, nothing. It's a little short penis. And this is the veru. So, and all the time when I was examining the child, there was no dribbling of urine, at least on table. It was dry. So
ma'am, what is the size of the scope?
So this is 7.5. I'm told it's yeah, anyway, it's 6.5. It's not 9. I wanted preferably a 9, 30 degrees, but I think we don't have that. So anyway, this is the bladder neck. So, and you can see the veru. It's very close, and it's a bit shorter. And we are entering the bladder neck. So which is closing. The child is on mask only. So we are inside now. So now there is a doubt of a ectopic ureter. So this is one ureteric orifice, which is on the right side. This one. Although the scope is not very good, so I'm not sure. But to me, definitely it looks like a right ureter.
Yeah, we are with you. We can say.
Can you see it?
Yeah.
Yes, ma'am.
Yeah, this one. So ideally, I think this child should have undergone a MR urography specifically for all this. So we will now look. So there's nothing much on this side. I can't make out anything. So we'll come out. We'll just see again for any. So because this child has multiple other anomalies. So one is the ARM, then hypospadias, then the tethering of cord, some L5S1 problem, and then anesthesia has also diagnosed that the child has got a aortic stenosis with regurgitation, for which the child has not undergone any surgery. But still, there are multiple problems.
What about bladder neck?
So yeah, we saw the, so anyway, the trigone doesn't seem to, when you can't make out, I'm a little unhappy with the scope. But I can't really see it as a ureteric orifice over here.
Ma'am, you were telling something about the degree of the scope, what you want.
Yeah, I
explain?
prefer 30 degrees because I have a better view, especially when I'm looking down to see an ectopic ureter. I definitely prefer 30 degrees. So I think we should all have one, what is called deflux scope sort of thing. So
10 degree?
10 degree.
Sir, Mane sir is here, I need your comments.
And I normally prefer to use a 10 degree only. Especially most of the work that we do is apart from PU wall where we use a 0 degree. But rest like a deflux and Dexel, so ureteric openings easily seen with a 10 degree. As soon as they go to the bladder neck area, you see immediately the ureteric openings, just turn the scope. So most of the time we manage with a 10 degree, but to have additional 30 degrees is an unnecessary investment, you know, the large amount of investment.
So this is definitely at the trigone on the right side. I mean, this is the trigone. So anyway, so I'm withdrawing now. See, the picture is not good. The particular program is not correct. So whoever uses it routinely should tell. No, we're going on changing something. I don't know what you're doing. But we are actually, this is just, it is just part of it.
कैलकुलेट करके देखो बच्चा बीच में कुछ दिखता है ना
हाँ इसमें कुछ दिख रहा है
हाँ यार कुछ है मतलब कोई होल सा
मे बी प्रीवियस पिछला का भी ओपनिंग हो सकता है
नहीं ये थोड़ा ज़्यादा ही ऊपर है
डिस्टल तो वेरो है ना ओपन हो रहा है कैलकुलेट करके यूरेटिक ओपनिंग यूरेटिक करते हैं
नहीं ये वेरू में ही है दिस इज वेरू दिस वेरू ये वेरू है ये. So this may not, but we can cannulate, but then we'll have to do some
Focus
dye
करना
study.
है?
What is this?
No, there is a small opening here, this
Yeah.
one. So this is in the veru actually, so it need not be that an ectopic, but
We were
yeah.
also asking about bladder neck. So bladder
No, this is bladder neck.
So you have single opening inside.
I have a, yeah, I
right
have
का
a,
देखते हैं.
there is a right ureteric orifice here, this one.
Yeah.
This is the right ureteric orifice. And we can't really see it, not yet. We'll just see whether there's anything here. No, actually the picture of the filter or whatever, that is not correct.
Sister, आगे जाइए इस पर. आजा बेटा.
मैडम आपको फोकस
तू
करके
आजा.
चाहिए.
हाँ, ये
वेट वेट
focusing
वेट
ठीक
इधर आ
नहीं
जाओ
है।
सिस्टर. सिस्टर इधर जाओ.
ये पीछे गिर
कर लो.
रहा है। ये माइक वगैरह निकल, आप देख लीजिए, आप पकड़ लीजिए. हाँ? लेकिन आप बार बार चेंज मत करना. हाँ, ठीक है. We are just coming out because we are not happy with the. So I'm not yet sure about that. So we are just going in again. You have to remember that the child has undergone a proximal hypospadias surgery. So after
a
this,
detethering
now we are
is there.
seeing the veru. So I think these are just part of the veru only.
Ejaculated ducts.
Yeah. So now the picture is much better. The scope has been changed. So now we look at the.
For those who are sitting in auditorium, the view shown by earlier arrangement was better, much better.
Okay,
Can't-
but for us
can't-
here,
Yeah.
yeah, for us the vision is actually better now. I don't know. I can't say. There were a lot of other, like a honeycomb pattern seen on the scope.
Prema, can you show the bladder neck, please?
Yeah, yeah. I heard you. So I'm just withdrawing.
No, before you
Yeah, I'm
withdraw,
fine.
can you
Yeah.
empty the bladder and again show us the bladder neck? Because I think
Yeah,
there
yeah,
are.
I'm showing you the bladder neck now. I'm coming out
no,
of the.
no, don't come out. Empty the bladder and
Okay,
then
okay.
show the bladder neck. We'll need to have a little clearer picture. This is very hazy here.
Yeah, yeah. Okay.
Yeah, child is now urinary incontinent. So we are here to know what is the cause of incontinence. Initially we thought that tethered cord is the cause. So we did a detethering of the cord. Even after that the patient did not improve.
बंद कर. ठीक है. Not 0. This is 30. This is 30 degrees.
Right.
हाँ. This
Okay.
is veru. So can we show from our OT? Not sure.
Okay.
No, are we seen in the OT hall?
Oh, yes.
Okay.
Yes.
Okay.
Yeah.
We'll see for ourselves first.
Okay.
This is veru, much better seen. Color, everything is good.
Yeah.
We're going in. We are still.
Yeah.
Bladder neck is a little open.
Mm-hmm. Mm-hmm.
I'm seeing one orifice here,
Mhm.
right side. We'll just check if there's another opening. There's no other opening as such.
Okay. That much is the gap. So, what is the gap in terms of millimeter? I mean, we can't make out what is the degree of magnification here.
So we're back with the trigone. What I think is trigone.
Okay.
This is trigone.
And the
You can see
dilator
it.
is not possible through the stricture, a
It's
small
just coming
size,
out.
even the small size.
Right.
See the bladder capacity is reasonably good.
Okay.
It's not bad. It is smooth. Yeah.
Yeah. Yeah.
This is the bladder neck.
Deepak, can I go back to Prema for just for a minute? Prema,
Yes.
can you go back to the bladder neck? I think at 3
Yeah.
o'clock
No,
position
this
we
is
can see
the-
some dimple.
Hello?
Yeah, yeah.
Just
Deepak
at
sir,
that level,
do you plan
if you go
scopy today?
towards the left side.
Cystoscopy?
Okay, so
Yeah.
this is the,
This is the right
slightly
ureter.
to the right.
Yeah, then come down a
Yeah,
little
so
bit.
this is the trigone. Although it becomes flat
No, you
later.
come down a little bit
Yeah, yeah, sure, sure. Just coming. So
Yeah, yeah.
I'm coming out.
and move towards left side.
So yeah, sure.
So what is there?
Yeah.
That's the ureteric orifice. That's
Yes.
what I saw in the first sitting.
Yeah.
That's your ureteric orifice.
Huh. So I think this was probably noted in the previous scopy also. and I think he's done an RGP at that time. So if that films are available, then we need not repeat this. Otherwise we can do an RGP now. So this is just, it is slightly more distal than the right orifice, more open. But bladder neck is starting now. This is the bladder neck coming. No. This one. So it's a little open here. Maybe just at the bladder neck, this left orifice. But slightly inside. That's why the bladder capacity is not that small. This child passes urine every 3 to 4 hours and then also dribbles. So he has some control. It's not that he is incontinent all the time.
Yeah, Prema, it looks to be just at the bladder neck, and in fact, even the right ureter is actually opening medial compared to what normally it should be.
Yeah, I agree. It is more medial.
So both are actually ectopic ureters, but intravesical.
Yes, yeah. But bladder neck can work both ways. So, yeah. So now this is the posterior urethra, and then we are coming out. Yeah. Now we are in the hypospadiac, the operated, probably that kind of area. So I think if Dr. Deepak can show his RGP, then maybe we need not repeat. Otherwise, we can do this RGP now. That's the only thing which is pending. So maybe Dr. Deepak can answer that. So the RGP which you said. So this is the same which you have seen earlier. Yeah. Yeah. But the only thing is we are definitely seeing a right side orifice, which you said was probably not there. I think.
Yes.
Yeah, so this we can see.
Yes.
And I also feel that on the MRI, at least I felt there's a small kidney on the left side, but that's an old MR. And it was done for the spine, not for the kidney. So if you have the RGP, maybe you can share that film.
Yeah, I don't have right now.
Okay.
Yeah.
So should we do that now? Should we cannulate and do it, or because child is on mask anesthesia? So this is just near the bladder neck. So you can decide.
So
but other than that, there's no other opening.
What is the purpose of doing the RGP? Sorry.
I think because the child is incontinent, maybe that was the reason they did it.
No, but
now there is no.
Yeah,
if you already have a RGP, I'm not repeating it. I'm just saying that it would be useful.
We know that the ureteric orifice is below the bladder neck.
Yeah.
Just below the bladder neck. So we know the cause of the incontinence.
At the bladder neck, I would say.
Okay, yeah, but we know the cause of the incontinence, what I'm saying.
Sir, now the question is, suppose I do a ureteric implantation in this patient, whether the child will be benefited?
No, I think first we'll have to, we have to first check the function of that kidney. I'm not yet sure about the cross-fuse thing, but so I'm coming out because I think we have seen that.
That's the repaired urethra.
Yeah, this is the repaired urethra.
Deepak,
so
I think the ideal thing to do would be an MR urogram and a DMSA scan to find out what is the functional status.
Yeah.
Yes.
And based on that you decide what is the next step.
Yes. I have also suggested MR urography done properly would help us. So he has a reasonably good bladder capacity, and obviously right kidney is working very well. I'm not yet sure about the left side, and also it is very ectopic, so we'll have to think about a duplex also, because that small kidney which I see on the left side is very, it is pushed inferiorly and laterally.